Okay, good afternoon or good evening, wherever you are in the world that you may be joining us. Thank you for joining us. We're going to just give it about a minute to let those of you attendees to jump into this Zoom webinar. But again, thank you for being with us today. We have a lot of great presenters today. And for those of you who are new to us, this is a webinar being sponsored by the Society of Bedside Medicine, the Stanford Center of Presence, and the Stanford 25, which is a part of the Presence. And essentially, much of what we're interested in various ways is improving the patient and a caretaker connection, whether it's through the physical exam or through communication. Really, it's a very open general thing, and it's something that we're very passionate about, particularly since COVID-19 came. It's been something that we've been worried more about and more passionate about than ever, which is the reason behind starting these webinars. So thank you again for joining us today. For those of you, again, who haven't been to this before, this is a joint multiple university project. And again, we're focused on the topics that we're going to be discussing today surrounding the patient-physician connection and the exam and those types of related topics. So we're going to ask if those questions you do have for us, try to focus those questions around those related topics. The questions that are way off those, today we'll probably stay away from answering, but we'll try to get to as many questions as possible if there are plenty. With that being said, I'm going to turn over now to Sonia Tadani. She's the executive director for both Stanford Presence and the Stanford Medicine 25. And thanks to everybody for joining us, to all our attendees and our panelists. Sonia, I'll turn it over to you.
Thank you, Errol. Welcome, everyone. Appreciate you joining us. As you heard from Errol, this is who we are. This is who I am. Next slide, please. The society was created by a number of founding and institutional members. You see all of us listed over here. If you are interested in joining the society, either as a member or as an institutional member, please come to our website and learn more about us and contact us through that. Next slide. While our work, as you heard from Errol and you'll hear through the rest of this webinar, is very much about focused on the bedside, we are cognizant of the fact that today we're at a historic point in our country. And I'd like to start with two quotes captured from a Stanford Rally for Racial Justice last week, organized by our Stanford pediatric residents. The first is Kamal Jones, who said, "We find ourselves at an all too familiar and horrible crossroads once again. And the question that we have to ask ourselves is, what are we going to do differently in this moment to ensure that future generations are not having the exact same conversation that we are having right now?" The second quote, also a Stanford pediatric resident, Salma Dali, said, "When I put on my white coat, I recognize the immense privilege that comes with it. But this coat does not make me or anybody else immune to the racial injustice that runs deep in our country. We are all fed up and we need change. We're here today as advocates for the Black community, and we're making a commitment for real change towards racial justice." Next slide. Apathy is no longer a choice. I invite all of us to observe 46 seconds of silence to honor those who have paid the price of racial injustice in our country. Starting now. Thank you. Next slide, please. As you heard, we are the Society of Bedside Medicine. This series of webinars, of which this is the second, is focused on COVID-19 and other realities in 2020. If you'd like to get CME credit for this particular webinar, you'll get instructions via email after the conclusion of today's webinar. Next slide, please. This is how it will be done. We'll also send this to you via email. Next slide, please. This is our agenda for today, and we've changed it a few times to be cognizant of the evolving world around us. I'm Sonu, as you heard, welcoming you. Our first speaker today is going to be Rhea Boyd from the California Children's Trust. She's also a pediatrician here at the Palo Alto Medical Foundation. She'll be talking about mental health effects of police violence and prescriptions for moving forward, followed by Donna Zulman and Megha Shankar talking about Telepresence 5 for COVID-19. Then we have Lars Osterberg talking about the Veterans Administration COVID tent, followed by Dr. Nicole Azam from the Edinburgh Center for Endocrinology and Diabetes, talking about COVID and diabetic populations in Scotland. And then we have Junaid Zaman from the Royal Brompton Hospital and Imperial College in London, talking about a new series we're adding that we call Hidden and Here during COVID-19, which are stories that are hidden about the reality of life during COVID-19, but very here and very present. And finally, Stephen Russell will be closing for us from the University of Alabama. Next slide, please. Thank you for joining us, and I'm going to turn it over to Rhea.
I was muted. Thank you for having me. Again, as Sonu said, I'm a pediatrician and child and community health advocate who has been working over the past 5 to 10 years to address the public health effects of police violence. And so that'll be my presentation today. We're going to talk about policing, pandemics, and protests and what the implications are for health. For folks who are interested in asking further questions of me or engaging on these topics further, I listed my Twitter handle below, which is an easy way to always reach me. So let's start with COVID, which is really the background in which the current civil unrest we're witnessing in the United States and really across the world in which it started. This is data that's looking at, it's county level national data that's looking at rates of COVID mortality, comparing areas that are predominantly non-white to areas that are predominantly white. And what this data is showing and what this figure is showing is that that top box, 17.8, and that lower box, 2.85, are mortality rates based on the percentage of population of color. What the data found is that at the county level, for individuals who live in predominantly non-white counties in the United States, the rate of COVID mortality is 6 times higher than those who live in counties that are predominantly white. This is particularly true for majority Black counties, and this is data here that was reported and captured by the Washington Post. But again, we have to place even that understanding within a long-standing epidemic of premature death in this country for African Americans. So African Americans right now have the second highest all-cause mortality rate of any racial or ethnic group in the country. They're second to Indigenous Americans. For decades, African Americans had the highest all-cause mortality rate in the country. And so when we think about increased risks of death from COVID, we have to then situate that pandemic inside the epidemics that have existed for Black people in this country and better understand what those roots are. So when we talk about the risks for COVID infection and complications, we need to talk about it in a specific way. And here I put an asterisk next to the word risk to remind us that instead of thinking at the individual level, where quote unquote individual kind of risky behaviors could possibly increase your risk for illness or disease. I'm talking now at the population level, where systematic factors that disadvantage certain populations make certain racial and ethnic groups at the population level more at risk for disease or illness than others. And so when we're thinking specifically about COVID, we have to think about what rendered African Americans, Latinx, Indigenous, and Native American populations more vulnerable to illness. And it's not simply poverty, as we've seen quoted in the media, or underlying illness. It's that we live in a country that has a legacy and continues to practice forms of racial exclusion, discrimination, disinvestment in communities, and violence, as we've seen in policing, that concentrate disadvantage, create adversity, and shape population level opportunities for health and provide the conditions for illness or disease. So we have to be very nuanced in how we talk about the disproportionate risks for COVID for certain racial and ethnic groups like African Americans. And one of those areas that we have to start focusing now on when we talk about disproportionate exposures to violence is absolutely police violence. And although the public is more aware of this issue because of the untimely and devastating public executions, frankly, of George Floyd, because of police shooting Breonna Taylor and Tony McDade, and because of the recent lynching of Ahmaud Arbery, we also have to understand that every year around 1,000 people are killed by police. 1,000 people. Data from the National Academies of Sciences has further told us that African Americans are particularly at risk for this deadly exposure. They estimated that 1 in 1,000 Black men and boys will be killed by police in their lifetimes. So I'm a pediatrician, and when I tell the statistic to my colleagues, I always follow it up with the mortality rate for measles, which is also 1 in 1,000, right? 1 in 1,000 is the mortality rate for measles, and when you think about the near constant public health investment we have placed in eradicating measles, and you compare it to how we are just now talking about a public investment in addressing the impact of police violence on Black folks' lives, you have to understand how complicit our system has been in allowing police violence to continue to take a disproportionate toll on Black folks. And that is a form of structural racism. When we talk about police violence, though, the cases that tend to end up in the news are often those that result in death. This is data looking just here at the state of California where I live, and obviously where Stanford is situated, that shows you that actually injury is a more common outcome when force is used in a police encounter than death. And so we have to think more broadly about the type of health effects that police violence can cause. And we'll jump into some of those. But I also want to pinpoint right before we do, when force is used in a police encounter and you look at the reason people called police in the first place, the number one reason was to call for service, right? I want to pause there. People call the police for help. And force is used. Nearly 50% of the time, that force results in a serious bodily injury. And here in the state of California, from the data as recent as 2018, 20% of those times force was used resulted in the death of somebody who called for help. This is why people are protesting. The system is deeply, deeply broken. So what are the health effects? We know that the victim who is the recipient of that form of violence, as I said, is at risk for injury, disability, death. We have to think about their risks for being introduced into the carceral system via arrest, incarceration, and the mental health impairments that are associated with either being a victim of violence or with prolonged incarceration or surveillance. But we also know something specifically about what it means to witness violence. Medicine has studied this for decades, and we know that witnessing violence increases an individual's risk of mental health impairments like anxiety, depression, PTSD, substance abuse, For children, it can manifest in headaches, chronic headaches, sleeping changes, changes in behavior like irritability for young children, or increased withdrawn or isolated behaviors for teenagers. And it can result in school failure or suspension and expulsion. There was also a study that I want to draw everyone's attention to in the Lancet that was really profound. It looked at what is the mental health effect of police killing one unarmed Black American in your state. And what they found is that the mental health impairment that results impacts every other African American in the state. So when we're talking about witness violence, we're not just talking about the people who were standing right by and who saw it happen right in front of them. We are now talking about people who witnessed it through their cell phones, on the internet, through news media, and through shared secondhand accounts from other people. That impacts the mental health of every other African American in this study, at least at the state level. And you have to wonder, given the outpouring of outrage about what happened to Mr. George Floyd, whether or not it happens also at the national level. And what they found is that the size of that mental health burden is analogous to the mental health burden associated with having diabetes, which is enormous, right? Diabetes is something that is so debilitating. Sometimes people lose limbs. And so it's deeply debilitating, and it causes depression. And the way Black folks respond to police killing another unarmed Black American in their state is to have a mental health burden akin to if they actually had diabetes. The burden is profound. And so we in healthcare have to start asking more sophisticated questions about how racism impacts health. And we specifically have to start thinking, how far are we willing to go? And how prepared are we to actually address the impacts that we're finding? Here's one example. A question we should start asking is, how does police violence shape the social and economic mobility of Black children? I draw on this because this is a figure I show in nearly every presentation I give. It's from Raj Chetty, who used to be at Stanford, who is now at Harvard, and it's looking at the economic mobility of children in this country by race and gender. These maps are particularly looking at boys, and it's comparing Black boys to white boys. If you look at the green map, it essentially illustrates that no matter where a young white boy grows up, he is likely to earn more in adulthood than he did when he was a child. And in that sense, it pays to be a white boy in this country. If you look at the red and orange map, what you see is that it doesn't matter where a Black boy grows up, because essentially everywhere he lives, he is less likely to earn more in adulthood than his parents did when he was a child. That essentially shows that there is nowhere where it's safe to grow up as a Black boy in this country. As the researcher said, in 99% of neighborhoods in the US, Black boys earn less in adulthood than white boys, despite growing up in families with comparable income. And there's more. This holds even if you grow up in families that have two parents, even if those parents have comparable income, education, and wealth. And this is the kicker. Even if those parents live on the same city block and those little boys go to the same exact school. What this is getting at is the roots of the current inequities that we're facing, that people are also uprising against in the streets, is not just legacies and histories that used to exist, right? It's not just segregation and how it affected us then, because this is happening even for boys that go to the exact same school and live right with each other on the same block. So what is it? Researchers found that the gaps in mobility between Black and white boys are smallest in areas where there's low racial bias among whites and high father presence among Blacks in Black neighborhoods. I wanted to think about this specifically in terms of what we're seeing with policing and COVID right now, right? If there's high father presence in Black neighborhoods, that's not Black presence Black father presence in your own home, that's just seeing Black men on the streets. And when you think about what are the forces that are literally systematically plucking Black men out of Black communities, you have to start talking about police violence. And when you're thinking about how racism impacts Black kids long term, you have to think about how white racism in Black neighborhoods contributes to that extraction of Black fathers. So I'll conclude by saying racism kills people, and we have to understand that in medicine. And these protests, there's been a lot of concern about protests increasing exposures to COVID, but we in healthcare have to take the stance that protest is a powerful affront to racism and the inequality it creates. And thus we have to consider it a powerful public health intervention. Thank you. So I'm going to pass it off now to Doctors Megha Shankar and Donna Zulman.
Thank you, Dr. Boyd. That was a really powerful presentation about issues that we need to keep front and center right now, racism and structural racism that are affecting the safety, health, mental health, healthcare access of our patients. And themes that we are really central to a lot of the work that will be discussed in the next few presentations. My name is Donna Zulman. I'm an assistant professor at Stanford in primary care and population health and at the VA. I'll be presenting today with Dr. Megha Shankar, who's one of our fellows at Stanford and at the VA. We've been working together with the Presence Center on the Presence 5 project, and more recently, Telepresence 5, thinking about how clinicians can best foster meaningful connections with patients during COVID, during virtual visits. Next slide. So this work is part of a larger project called Presence 5, where our objective has been to develop a simple, scalable, evidence-based intervention that fosters physician humanism and patient connection. For this project, over the last couple of years, our team has conducted a systematic literature review, observed clinician-patient interactions in 3 diverse settings, and interviewed non-medical professionals about how they connect with the people that they work with in fields as diverse as social work and education, firefighters, documentary filmmakers. And our goal was to synthesize these findings to provide some recommendations for clinicians about the practices that they can use, things that they can do and say to connect on a meaningful level with patients. And here you can see the recommendations that we put out in January. And this was, of course, just before the COVID-19 pandemic began and our world changed. Next slide. So the work that we had done was focused on the context of in-person interactions, and shortly after we put that work out, the world rapidly shifted to widespread use of telemedicine, and that has changed the clinical encounter in many ways. And our team went back into the literature at that point to look at how we could adapt the Presence practices for the virtual visit context. So we reviewed, started with over a list of 800 articles. It came down to just a couple of articles that provided evidence-based strategies for humanism over telemedicine. We got feedback from clinicians and put together some recommendations that are available in a CME video for those who are interested. And so we wanted to share those recommendations with you today. If you go to the next slide, I'm going to turn it over to Megha now, and she'll describe the Telepresence 5 practices.
Great, thank you so much. So we'll jump right in. So for the first practice, it can be really important as at this time, a lot of us have back-to-back appointments. So we can stand up and simply take a deep breath in between. We might even do a simple stretch to kind of pause and refresh. At the same time, we might meet a patient for the first time over the screen. So it can be really important to really learn about their social aspects. Finally, doing things like putting your phone away, closing the door. If you're in a shared space, maybe use headphones to really focus on who's in front of you. Next slide. So for the second practice, it can be very helpful to sit up, lean forward, and stay in the frame, and really important here is to look at the webcam. And on the screen, we often have the EMR, the patient's face, and we're not sure how to navigate through that. So one tip here is to minimize the patient's screen as much as you can and move it as close to the webcam as you can. Finally, it can be helpful to, with all things IT, there might be lag time. And so just to pause before we jump right in. Next slide. The third is to agree on what matters most. And in addition to asking about a patient's goals, using open-ended questions and teach back, in this case, it can be most important to reassure that you are there for them for as long as you need to. I think oftentimes patients get concerned that this might be the only chance that you will see them, but it can be helpful to let them know that you will be there for them throughout. That's great. And so to connect with the patient's story here, we really kind of go back to the days of house calls where we see the patient in their home. In this case, we might see their pet, or we might see family, and we can learn that they have people to help them out with meds and things like that. We might also ask them about their home environment and how safe they feel there. Next. Finally, we may think that it's hard to explore emotions during this time, especially through the screen. However, we can use things like tone and volume of speech to really hear what people are expressing, and of course to just ask them how they feel. In this case, the words that we choose can be really what patients hear, especially if we just use phone. So it can be helpful to really think twice about what words we choose to speak here. Next. Great, thank you so much. And as we switch from the bedside to the web side, we can really think about how to maintain that care in everything that we do. And I'll hand it over to the next speaker.
Hello, everybody. I'm Lars Osterberg. I practice at the Veterans Affairs Hospital in Palo Alto, California in primary care. I'm also a Stanford faculty here in the School of Medicine. A little background just about the Veterans Affairs hospitals for those of you who are not familiar is, we see a large proportion of men, mostly with many cardiac and pulmonary diseases. And as you can imagine, in the era of COVID-19, evaluating these patients can be challenging because many of these patients come in for exacerbations of their cardiac or pulmonary disease. And sometimes this could be related to COVID-19, or it could be something else. And so we also wanted to minimize the risk of exposing these patients to others who could have COVID-19, particularly given the high risk that these patients have for poor outcomes if they become infected with the SARS-CoV-2 virus. So we also wanted to efficiently screen people who needed COVID-19 testing or low risk, so not needing, say, emergency room treatment. So really our goals were, one, to have large-scale testing and screening available to those who need COVID-19 testing, avoiding exposure of patients to others who potentially have COVID-19, and then effectively and efficiently evaluate and treat patients with respiratory complaints in the population at the Veterans Affairs who have these significant chronic cardiac and pulmonary diseases at high risk for poor outcomes if they were infected. So next slide. So point number one is enabling large-scale testing of COVID-19 in patients under investigation, or PUIs. So we developed a swab and go process for patients with low level need for evaluation. Those could be quickly screened through our process. And then urgent care patients could be evaluated for their respiratory complaints. And this was all done through a team, as you can on the slide of the pictures there, of a team of a dental swabber, we call them, who could swab the patients. And there's a physician and a scribe, and then a nurse that's evaluated, that's part of the team. And the gentleman to the far right is one of our previous residents here at Stanford, Matt Stevenson, who is part of setting up this process and really involved with this continuous quality improvement process of this respiratory outpatient tent. So patients started with a telephone screening process. We have a robust primary care system at the VA, and patients would call into this 24/7 line where they would have a telephone care nurse, and they could help triage over the phone as to what level of care they might need. They would then come to the Veterans Affairs Hospital, and at the hospital there is where we'd have on site in the parking lot this core team that could see them with on-site radiology labs and pharmacy, where patients could get all of this done through the parking lot. And then immediate ED consultation if we found that the triage was inappropriate and they actually had to get emergency room treatment. And then finally, an automated results callbacks that was done through the telephone care program, so that after we had seen patients and the results come back, that the patients could be counseled on the results. Next slide. So the second point is really avoiding exposure of patients under investigation to other patients who may not have the illness, and also avoiding exposure to staff. So really what we wanted to do is keep patients in the car. And as you can see in point 1, they drive up, they finish the triage process of getting vital signs, all done through the car window. And that's done by our emergency room triage team. So if the patient needs more extensive care, they would then go to the emergency room. The second would be is if they are meeting the lower level triage, they would see our respiratory team. And that, as you can see, is the tent there in point 2. Now, if the patient comes in through walk-in, which happened occasionally, we could still see them in the tent. And as you can see in the back there, there's availability of seeing a patient with behind the blinds, where they could actually be seen out there in the open. But our goal was to keep the patients in the car to provide the majority of their evaluation. And therefore limit the exposure to others. Next slide. So really the goal is effective management of patients with outpatient respiratory complaints, evaluating them in the car with the emphasis on the clinical evaluation, minimizing the need for leaving the car. And again, as I mentioned, having radiology, lab, and pharmacy pickup all done through a drive-through process. So this could be done with the patient actually never even leaving the car. And as you can see in the window to the right, this patient's undergoing COVID-19 testing through a nasal swab, but also the history in the exam is done through the car window. So for example, the history could be done even with the window closed with the patient on their cell phone. We had a cell phone for the physician and the nurse so that they could talk to the patient, avoiding any potential exposure. And then when the exam was needed, the patient would roll down the window, and it's amazing how much you can do through the car window. You can lie the patient down, for example, to look at their JVP if necessary, if the seat could recline. You can have the patient lean forward and turn to the right side and perform a respiratory examination. We were able to do cardiac examination. We had portable lights and otoscopes to evaluate HENT. So really, the only issues that we couldn't deal with occasionally were, for example, a skin exam or an adequate abdominal exam. And occasionally we'd have to bring patients into the respiratory tent to actually perform those. We really, also, I would say the other issue that could be challenging to implement this at other sites is obviously the weather. We're fortunate in Northern California to have nice weather, and we don't need to worry about snow or extreme winds, and so as you can imagine, this tent may not work well in other parts of the country. But fortunately for our environment, it actually was a nice way to perform care and one-stop shopping and keeping patients in their car. Okay, so last slide. So in summary, we're able to perform large-scale COVID-19 testing through the car. We were able to minimize exposure of patients with COVID-19 by keeping them in the car for their complete clinical evaluation, and then an efficient evaluation and management of patients with respiratory complaints. And as you can see there, the pharmacy where they could drive up, and then a pharmacist bring out the medications if needed. The history and exam and COVID testing all done through the car window. And then finally, even laboratory testing if needed, or radiology all done in the parking lot. So I'll pass over the baton to Dr. Nicole Azam, and we'll talk about COVID and diabetes. Thank you.
So thank you very much. My remit was to bring an international perspective to this meeting, and I'm a diabetologist endocrinologist working in the Edinburgh Centre for Endocrinology and Diabetes in Scotland, and I'm going to tell you a little bit about how our outpatient interactions in diabetes have evolved during this COVID pandemic. Next slide, please. Within our centre, most of our consultations moved to being delivered by telephone from mid-March onwards. We have made some use of video using a platform called Attend Anywhere, but predominantly telephone, and that's mostly what I'm going to focus on. There are 3 key points that I'm going to cover in my talk, and I hope to pick up on some of the points raised in the previous Telepresence 5 talk. I'm going to spend most time talking about how we prepare for the diabetes consultation, and I'm going to extend a little bit what was discussed in Telepresence 5 by considering not just how we prepare as clinicians, but how we support the person with diabetes to prepare for the consultation themselves. I'll say a little bit about how we can tailor parts of the diabetes examination to the virtual consultation, and then I'm going to end with telling you a little bit about some feedback that we've gathered from our phone consultations. And again, I would bring this back to some of the points raised in the Telepresence 5 talk. I think we need to listen intently and completely and agree with our patients on what matters most to them in relation to that individual consultation. But I think we also have a duty to apply those same principles to how the consultations are conducted at that point and in the future as well. So I'm very deliberately going to use UK and Scottish information and resources and focus just on the outpatient setting. Next slide, please. So thinking first about how we support the person with diabetes to prepare for the consultation and what we do in the build up to that phone appointment. Our patients all get a letter and a phone call from an administrator explaining that the appointment will be delivered by phone. The letter gives them information on some of the things that they can do to prepare for it and refers them to educational resources on our website. When people come to clinic for a face-to-face appointment, we use a platform called Diasend, which will either Bluetooth or plug into most commercially available blood glucose meters. And in the face-to-face consultation, we would share that data on a screen and discuss it with the person with diabetes. What we're encouraging people to do is to download this data at home, and they can share it with us securely on our clinic platform. And if they've done that before the appointment, it really makes the interaction much more meaningful. As clinicians, we know at the moment that we're going to want to spend part of the consultation discussing sick day rules. We know that if people with diabetes develop COVID-19 disease, they are at increased risk of diabetic ketoacidosis, regardless of whether they've got type 1 or type 2 diabetes. And so we're going to speak to people with type 1 about testing ketones and about taking correction doses of insulin. And for people with type 2, we're going to speak about relevant medicines that should be discontinued, most particularly the SGLT2 inhibitors. Now that's quite a lot of information to deliver, and we want to spend a large part of the consultation listening and interacting, not just talking at the patient. And therefore we felt that if we asked people to look at this information before the appointment, we could then use the appointment to reinforce the key points or answer any questions, rather than simply delivering a barrage of information down the phone. So that's some of the work that goes on beforehand. On the right-hand side of the screen, you'll see a download from a flash glucose monitor, and it shows you a continuous trace averaged out over 2 weeks for a particular patient. And importantly, it also gives an estimated HbA1c. That's one of the things that people are used to getting when they come up to our face-to-face appointments, their blood sample and their real-time HbA1c result, but downloading the data and sharing it beforehand gives us a proxy for that we can share with the patient. On the left-hand side of the screen, you'll see a screen grab from Sky Diabetes, which is the platform that we use for all diabetes consultations in Scotland. And this is a really useful platform because it pulls in data from community podiatry, from our national retinal screening program, from blood pressure measurements, from blood tests that are done in primary care. So we can see all of the relevant data gathered in the one place. There are also short decision support messages that appear on that platform, alerting us as to what tests are needing to be done as part of that person's annual screening program. So that really helps us as clinicians to be focused on where that person is in their annual cycle of diabetes checks. But importantly, we want to empower the person with diabetes to understand and access that information themselves. And in Scotland, we do that through a platform called My Diabetes My Way, developed by NHS Scotland. And that translates that information into a patient-friendly portal so that they can access their own data. So hopefully we've encouraged the person with diabetes to do all of that ahead of the phone call. What do we do as clinicians? Well, we want to think a little bit about the words that we're going to use, how we're going to set the scene. And I think it's important to ask the person whether they're able to speak at the time that you phoned them. There's been a lot that's been challenging about these virtual consultations, but I think there's also been a lot that's been very positive. When I do a face-to-face consultation with a patient, however hard I try, the balance of power rests with me. I invite the person into my clinic room. I indicate the chair that I'd like them to sit in. And even if I'm asking them to set the agenda, it's me actually telling them that they can set the agenda. The power is very much in my hands. But at the moment, that balance of power is shifted, and I think that's a really positive thing. The person with diabetes has all of their glucose data at home. They can choose to share it or not. And by asking whether it's possible to be invited into their home for a phone consultation, it really is putting us in a more even playing field. And I think that really sets the scene for a much more collaborative consultation. It's important, as usual, that we should ask if is there anything in particular that they would like to cover. And as Donna Zulman has highlighted, I think it's important to try and connect with them. And that's all the more important when there's no face-to-face connection. And I usually say something like, life is pretty strange just now. How are you dealing with it all? How are you doing? And that tends to open the door for the person to say things like, well, my mood's a bit low. I'm struggling to test my blood glucose. I'm not exercising much. I'm eating a lot. I'm gaining weight. And that's an opportunity for me to empathize on a human level and say, do you know what? I think everybody's struggling with that sort of stuff. And I've found that many of these phone conversations have actually been really positive and collaborative. Next slide, please. One of the other things that we know as clinicians that we're going to have to cover in a consultation, though, is the increased risk of adverse outcomes for people with diabetes if they develop COVID-19 disease. And again, you could pick data from China, from the States, from Italy, but I've picked British data to show you. And this is data that was published by Jonathan Balabji, the Diabetes Clinical Director in NHS England, and it was published by Public Health England on the 20th of May. You can follow the web links if you want to see the original data. I'm not going to read through all of the key facts that I've put on the slide in terms of odd ratios and hazard ratios. Those are the medical facts that I retain in my head. The key point is that as a clinician, I have to be prepared to discuss those risks in lay language. So the key things that I want to get across to the person with diabetes when they're worried about how COVID-19 will affect them is that actually, if they're of working age, the risk of dying of COVID-19 is extremely low, even although they have diabetes. And that those risks can be modified to a certain extent. I can't change somebody's gender or their ethnicity or their level of social deprivation or their age, but we can focus constructively on how to improve their HbA1c and how to help them control their weight. And these are factors that will improve their outcomes if they develop COVID-19. Again, this is another point where we cover our sick day rules with patients. So that's my prep, is really knowing how to convey that in lay language. But on our website, we also have links to a statement that Diabetes UK produced, and I've put the link at the bottom of that slide. That presents the facts from those Public Health England papers, again in lay language. Next slide, please. How about the diabetes examination? Well, that can be tailored to the virtual consultation. In Scotland, our eye screening is done by a national screening programme with digital retinal photographs. Unfortunately, that's currently paused. We would also often examine people's injection sites, and it's pretty easy to ask somebody with diabetes to just run their hand over their injection sites and check for lumpy areas. But the foot examination is a key part that we can't easily do over the phone. I won't spend too long going over this, but again, Diabetes UK has a very useful instructional video on its website that explains how somebody at home can enlist the help of a relative or a carer to do a simple touch test. And if they miss 2 or more of the 6 points on their feet that should be touched, it suggests that their feet are at risk. So anybody who's worried, again, we would direct them to this link on our website and ask them to do the touch test and feed back to us if there are issues. Next slide, please. Finally, I want to pick up on the feedback from our patients. And so far, we've only gathered feedback from 60 patients, but we're continuing to seek feedback. We had some positive feedback from a virtual clinic that we'd set up for women with gestational diabetes in the past, and those are the speech bubbles in the top left-hand corner. The speech cloud, the word cloud on the top right-hand corner shows some of the feedback that we've had from our phone conversations on this occasion during the COVID-19 pandemic. Some concerns, unsure of the plan, found it tricky, but a lot of positive comments. Brilliant, good idea, bang on, happy. And the graph on the bottom left-hand corner shows that people predominantly found the phone consultation useful. We were worried that people would feel that these were holding measures, that they didn't really manage to make any positive changes as a result of these interactions. But encouragingly, just over half of patients felt that they had made a positive change as a direct consequence of what was discussed by telephone. Almost all of them felt that their questions were answered, and interestingly, none of them felt that they would have preferred video as an alternative. We worried that a lot of them would feel that the absence of an HbA1c test was a real downside to the phone consultation, but only about 1 in 5 of them felt that they would have needed the blood test. The caveat around that is that almost all of our patients are doing home blood glucose monitoring, and if you were doing a phone consultation with people who didn't have data to share at home, that would perhaps change those answers. Next slide, please. So I'll really just leave you with some British resources there that you might want to dip into. We've got a screen grab from our clinic website on the top right-hand corner, edinburghdiabetes.com. There's links to the various resources that I've discussed during this talk. The other resource that I'll mention is the Royal College of Physicians of Edinburgh, of which I'm a fellow, and it's one of the institutional members of the Society for Bedside Medicine. Since mid-March, they've also had weekly COVID webinars on a Thursday evening UK time. Those webinars are available and anybody can log on to them for free. And in fact, several of the speakers who contributed to the SBM webinars also contribute to those webinars. For example, if you fancy a longer version of Donna Zulman's Telepresence 5 talk, you can find that on the RCP website. So really my key points are that not just the clinician, but the person with diabetes needs to prepare for the consultation, that we can do some bits of the exam over the phone, and it's important to gather feedback from your user group, regardless of which patient population you're looking at. I'll now hand over to my colleague, Junaid Zaman, who will give us our next talk.
Thank you, Nicola. So good evening from London. My name is Dr. Junaid Zaman, and I'm a cardiologist at the Royal Brompton Hospital in London. It's my pleasure to kick off the Hidden and Here series in the SBM at the Bedside during COVID-19 series. We wanted to share reflections from global perspectives of individuals centered on a unique personal experience. And it is my honor to speak to you on observing Ramadan during COVID-19. The Royal Brompton Hospital was one of the UK's very first hospitals to turn 100% COVID-19. What did that mean for us? It meant huge amounts of ICU training in a really short space of time to deal with the impending disaster of COVID admissions. The Royal Brompton Hospital is the largest specialist heart and lung centre in the UK. So we are referred the most complex cardiac cases of COVID-19 from across the country. So Ramadan, which is the holiest month in the Islamic calendar, really couldn't have come at a better time. As many of you know, millions of Muslims around the world fast for 30 days from dawn or overnight until sunset the next day. It is meant to be demanding. In the UK summer day, you can't eat or drink for up to 18 hours a day. And I can tell you from firsthand experience that fasting, whilst wearing a plastic apron, surgical gown, full face visor, and a face mask for up to 12 hours straight was even tougher. However, I did find that the PPE, as we call it, physically caused a sense of solitude. The noises around me quietened. I focused more on my breathing. It in turn allows one, and certainly allowed me, to automatically be more reflective and mindful of myself. What does Ramadan mean to me? For me, Ramadan is about three main things. The first element is one of sacrifice. The second element is the act of giving back. It is a Muslim's duty to give charity abundantly during this month. And the third element is to try be the very best person you can be during this time by displaying more humility, patience, and love. This year, in the month of Ramadan, it wasn't just me sacrificing and not by simply not eating or drinking. I felt like all of my colleagues were displaying the spirit of Ramadan with me by also sacrificing on a daily basis. Sacrificing time spent away from their families, sacrificing their physical and mental health, and some even sacrifice with their lives, all to serve others and to do their duty. As I mentioned, a key part of Ramadan is giving back to others. And I was amazed to see hundreds of local restaurants making food packages at their own expense, despite financial hardship for themselves, for the thousands of doctors, nurses, healthcare professionals, and hospital workers in the UK who are fasting all day for the whole month. The kindness of the local community was immense. And I got to share the meals I broke my fast with, which are called iftar, with my non-Muslim colleagues who are not only sacrificed as much as me, but also appreciated good quality Indian food like a lamb curry or a biryani. Yes, the mosques were all closed and no families were not allowed to break fast together, but I was still able to find that spirit of Ramadan well and truly alive by breaking my fast with my fellow doctors in a hospital. As a bonus, I also found a sense of transatlantic community by sharing the month with Abraham Verghese at Stanford, who observed the whole month out of discipline and solidarity with me, which was a real bonus for me. The last element of Ramadan for me is to try be the best human being you can be. And while I tried my own personal best, I saw people around me doing it tenfold. One example is the extraordinary efforts of my colleagues at the Royal Brompton to allow relatives see their loved ones by donating webcams and rigging every single bed space in the hospital with a working video link so patients' relatives could call in and see their loved ones along with their healthcare providers. Outside work, I saw the incredible kindness of strangers. I saw people reaching out to neighbors and family to make sure they were okay. I saw people caring for the elderly, sick and vulnerable without a single thought for their own safety. And there were nationally known, humbling, inspirational acts of charity by individuals aged 99 to 100 years, raising tens of millions of pounds for the NHS by their heroic acts, purely for charity for others. So yes, observing Ramadan last month could not have come at a more poignant time for me during COVID. It will be a time period in my life that I will never forget. One that truly renewed my faith in humanity. And whilst COVID will eventually go, the renewed bonds to each other we all have felt during this time will no doubt endure. Thank you very much for listening. I'm happy to hand over to Stephen Russell for the final wrap-up comments. Thank you.
Thank you, Junaid. It's my pleasure to end out the June session of SBM at the Bedside. My name is Stephen Russell. I work at the University of Alabama at Birmingham, UAB, in Birmingham, Alabama. And I'm so heartened by all who have joined us today in listening to each of our presenters in each of the presentations. One theme that I heard was the balance between physicians and providers and patients. When we put this program together, it was SBM at the bedside. But one theme that comes through with each of our presenters today is the redefining of the bedside. It's not necessarily in a hospital where every bed is filled with COVID, such as Junaid was describing, but it may be in the car. The bedside may be in the home, where we're invited in to be a part of the patient's experience. The bedside actually may be in unity at a protest, where we're invited to join with our patients as they express and experience and invite us to express and experience their own and our own struggles with what we're all going through as a community. And so I think that this particular moment that we have shared together over this last hour has helped us to think about what bedside medicine means, because it's not one place. It's actually where our patients are, and we can be there as a physician community to share in that with them. The next slide will demonstrate that there are resources that we have as the Society of Bedside Medicine that we'd like to share with you. And if you go to our website, bedsidemedicine.org, you'll be able to find some of those resources, such as a recording of this particular webinar, which we posted later this week. You'll also be able to find a recording of the webinar from May of 2020, and you'll be able to find recording from future webinars as well. You'll also be able to find resources such as telemedicine resources called the 5-Minute Moments for Telemedicine, where you can learn how to do telemedicine from a distance, remotely, such as what our presenters talked about earlier, Donna and Mega. And we certainly invite you to look there, as well as additional links to their resources as well. And finally, we invite you to join us next month. If you look to the next slide, you'll be able to see that we have a lineup that will talk about clinician resilience. We have presenters that will be sharing other experiences as well, such as practical pearls. We want to share information about how one might clean their POCUS equipment during a pandemic, as well as Junaid will be joining us again, talking about COVID-19 and the cardiology consultant. And then finally, we'll be talking about COVID-19 and intimate partner violence from a VA perspective. And so as we wrap up today, we want to thank you for joining us. We want to invite you to join us next month. But most importantly, we want to ask you to think about the things that have been shared today, the things that were shared in May, and be able to find ways that you might be able to apply that in your own practice and with your own patients as we work together to build a community where patients and providers partner together to bring that balance, where we can work together at the bedside, wherever that may be, to improve the lives of our patients. Thank you very much.
Great. I'm going to go ahead and shut down the webinar now. Stephen, thanks so much. Thank you to all the panelists, and thank you for all the people joining from around the world. We look forward to hearing from you again. Okay, guys, have a good day.
Errol, is the webinar done and it's just the panelists now?